Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. This is episode 2 of season 2, and this month I'm delighted to host Prof. Feroza Motara, who's one of the pioneers of emergency medicine in South Africa, and has had a career spanning the entirety of the specialization's lifespan in South Africa, as you will hear. She is the academic head of emergency medicine at Wits, and she is the clinical head at Charlotte Maxeke Academic Hospital. Today we're talking teaching, not only in emergency medicine, but also broadly for all healthcare students. And when I say student, in our field, everybody is a student for life. We touch on how to look past traditional ways of teaching EM. We touch on the expensive and not always appropriate short courses that are synonymous for some with emergency medicine. We talk about students in the hospital and how to balance mentorship with getting work done at the same time. And then we also chat about how to teach soft skills in combination with clinical knowledge. Without any further preamble, welcome to the show, Prof. Motara. Would you mind starting off by introducing yourself and giving us a bit of background on your career?
Morning, Dana. Thank you for having me and giving me the opportunity. All right, so I'm Feroza Motara. I'm an emergency specialist, a family medicine specialist, got a specialist qualification in health management, a few other diplomas. Pretty much been in public health medicine for the last almost 30 years, largely, in fact, I'd say 90% of that time in emergency medicine. Worked in emergency medicine at a time when it wasn't a specialty. So, in order to be a specialist, you had to do family medicine, and that's why I have the family medicine as a specialty as well. Seen it evolve over the years from not being recognized as a specialty to where it's really taken off right now and growing, by leaps and bounds. Apart from that, I'm the academic head of emergency medicine at Wits. I head the emergency unit at Charlotte. I'm a single mom of 2 girls, one of whom qualified last year as a doctor and the other one hopefully this year. And then I can retire because I've done what I needed to do. But yeah, that's we have lots of hobbies. Do lots of cake decorating and fancy embroidery stuff and things like that to keep me sane. And I love the Kruger Park. That's me.
Thank you. And as the academic head of Wits circuit, you obviously have a big interest and investment in education of emergency medicine. What draws you to that, or what would you say were the things that steered your career into the educational space?
Okay, so I grew up in a home with a dad who was a teacher, biology, and always had teachers around in the wider family. My dad's got cousins who literally, they're about 8 kids and 6 of them are teachers. So grew up in a home where, teaching was always there. I have a sister who's a school principal in Doha at the moment. So there's always been the education background. And my dad always said something which stuck with me is that without good teachers, you would have no doctors, lawyers, everything else. So it kind of that resonated. And I've always felt that if we want things to improve in the longer run, we want better doctors, we want better healthcare, we want, better overall socioeconomic conditions for people, that you have to give something back. And my giving back was not only in sort of clinical service, it had to have been more than that. And I found that niche in the academic part of, doing what I do. I still feel very strongly that if we want our junior doctors to be better doctors, and ultimately they're going to take care of us one day, hopefully, we want them to be of a standard and of a caliber that is something that we can be proud of. And I guess that's why I feel that the training of particularly EM specialists now in its still younger, sort of childhood phase as a specialty is so important.
And so I'm going to move on to specifically emergency medicine education without getting into the more technical topic of curriculum design, which I'm sure you know a lot about, but our listeners do not necessarily. But from a more basic perspective, I want to start off by asking a general question about emergency medicine teaching. I feel that, as not necessarily from a self perspective, but from many other people's perspective and undergrads' perspective and junior doctors' perspective, emergency medicine is seen as an extension or a expansion rather of the short courses that are associated with it, namely ACLS, ATLS, APLS, and even a DIPEC to an extent, where it's very high intensity stuff geared at emergency resuscitation, things like that. Whereas what we do on a day to day basis, that sort of thing maybe is 5% or less of what we do. And it's such a broader thing involving non emergency situation decision making. So how do we incorporate that into teaching emergency medicine?
I think one of the big things for me is that there still needs to be a greater realization and appreciation from our colleagues in the other specialities of what we do. It's getting there, but it really has still a long way to go. I think, for example, internal medicine, if you think of what they're doing now on a platform in any emergency patient, undifferentiated patient that presents to the ED, and like you say, excluding the CPR, resus patients, they're not really doing anything anymore. You think of a patient who's got an acute STEMI who arrives at the ED. It's our guys who are now interpreting the ECG, getting a trope, thrombolizing the patient, even making a decision about whether the patient needs PCI or not. So that realization and that paradigm shift in that space will change how things happen. I think for me, the undergrad space is where it needs to change. I'm not sure about our colleagues in the other universities, but at WITS, our undergrad students spend 2 weeks in emergency medicine in total. As in their 6 years of training. And if you think about every other specialty, it it starts in emergency medicine. And if they're not getting that basic grounding and teaching of what we're supposed to be doing, and the realization that, it's not just about CPR and ACLS and ATLS, as you said, it's more about making mental sort of paradigm thought shifts on how do you approach a patient with chest pain? How do you approach a patient with abdominal pain? So if I can change anything, it's going to be that for them to start learning approaches to things rather than managing specific things and being so bogged down on having all these courses. I mean, you just look at the doctors that are applying for posts and they come to you with a CV with like every resus course, emergency course, ECGs, neonatal resus, and they think that that's adequate and it makes them a good doctor in emergency medicine. So that whole thought process on how you make decisions, how you approach things, both at an undergrad and even at a registrar and a medical officer level, is for me what needs to change. So, getting people, and part of it is the way we teach and what we put out there and the focus. It always comes across as it's this high pressure, adrenaline rush kind of environment. And honestly, like you said, 95% of the time it's not that. You're seeing patients that you've got to sit and decide and figure out and look at what you have in terms of clinical signs and symptoms and results of tests and put it together and make a decision, for how it's a lot more thought intensive than just the adrenaline stuff in terms of a resus.
And I also feel that that is is often harder to do in terms of a lot of our education, a lot of the lectures we go to, a lot of the things online are geared towards not missing something. And these are the intricacies of pickups, and you mustn't miss this, and you have to look at the STEMI equivalents, you have to look at the subtle signs of a PE and be sure not to miss that. And emergency medicine is often about being confident enough to safely discharge someone. And
Yeah,
with 2 weeks of undergrad training in emergency medicine, where students have just been exposed to inpatients who they don't have to discharge in a hurry,
yeah.
it's the first time they're actually being faced with a decision about, is someone safe to go home or not.
You know, the resus patients are easy to identify, and you follow an algorithm, you know the ACLS protocols for an arrhythmia, you follow the CPR algorithms. Those are the easy ones to do, I think. It's when, to decide when is your patient about to crash and should I be putting him on NIV or should I be intubating him, and when not to and why. Those are the decisions that need to be learned and to be emphasized. And like you say, is a patient safe to go home, or does he need ICU, or does he need a ward admission, or can I refer him to an outpatient clinic, for example? So those clinical, and I think that comes with a bit of experience, with a bit of exposure. I'm trying at the moment to get our medical registrars to come and spend a rotation in the ED, because as I said earlier, they're not seeing the acute stroke and the acute STEMI and the status asthmaticus, because we're packaging those patients and sending them to them. So they're getting a nice stable patient in the ward, and they're not learning how to manage the acute pathology anymore. So, it's getting our guys to appreciate it, but also the wider group of specialists in the system to also appreciate the impact and the role that we play in that regard.
To go back to one thing you touched on with undergrad training, and to go back to the question about our short courses, like you said, these are algorithms that we learn, and those are the more straightforward processes that you have to manage when you know how to do them. Obviously, if you don't know how to do them, you run around like a headless chicken and you get a bit stressed out. But is there any capacity to incorporate those courses into our undergrad training?
From a WITS point of view, in that undergrad period, we do a basic life support equivalent where we teach them about CPR and defibrillation, almost a BLS kind of course without the expense. We do undergraduate airway course, so we've taken the AIM course and we modified it a bit so that we do a basic AIM course with them. So we are trying to introduce those principles at an undergrad level. But again, unless you can do as many courses as you want, unless you're in the environment and you're putting into practice what you've learned, it's meaningless. So the only way we can get around that is by actually getting people to spend longer periods of time in those rotations. And whether we actually extend just the EM rotation as an undergrad at an undergrad level, or we actually say that in every other rotation, for example, if you're doing internal medicine or you're doing surgery, that you actually come and do your call, or you do, part of that time in the ED to get that acute medicine exposure and to practice those skills.
And also just on like you said, the expense and the usefulness, if the skills are not being practiced, there are areas, for example, if you're working in a emergency unit in private, that's an appropriate qualification to be a prerequisite. A friend of mine was interviewing for a gynae reg post, and it was a prerequisite for their unit. And it's just like it seems to becoming more of a checklist, less of a people thinking about what you actually need.
Absolutely. And I think even in our environments, we interview doctors for medical officer post or for a registrar post, or, to write your part one exams, for example, it's a prerequisite that you have all these courses or equivalents of the courses. Um, I it's valuable in that it teaches you the algorithms, but I think it's more valuable in American and British environments where medical legal litigation is so huge that it almost, if you don't have that and you get into trouble, they'll nail you. And for us, it's more about providing almost, you know, for me, the value add of these courses is more for someone who gets posted, for example, com service in Fontaine, where there's nothing, and all you have is a defibrillator, and hopefully that will help you save a patient, if that. And to follow an algorithm to help you to go through a process. But in our more sophisticated environments, our academic centers, we have access to so much more. There's reasoning, there's access to ultrasound, there's blood tests, senior experience. And those things, I think, are more important for me in terms of your decision making and your clinical outcomes than having a course that, yes, you've done and you can tick a box to say, I've got it. But on the ground, don't know what to do with a patient.
Moving along to, you alluded to a few of these skills in your answer now. Senior supervision. Let's talk about soft skills in terms of leadership, cover, mentorship, on the floor education, managerial skills, staff management, people management. I feel a lot of doctors start out their careers as clinicians and end up their careers, or not even so late sometimes, moving into more managerial positions, teaching positions, things like that. But there seems to be a clinical prerequisite. It's clinical specialists becoming seniors and then becoming managers. What are your thoughts on developing soft skills and managerial skills from an earlier point of view?
So I think one of the biggest deficits in our medical training across the board is that we do not get taught things like finance management, things like administrative things. I mean, I know all our registrars do TATs just before exams and tell us how you would manage a disciplinary situation and tell us how, but that's the only time they worry about it because they don't get exposed to it on a day to day basis. And if you think of ourselves, the only time you've learned about it is when you've had to deal with a difficult doctor or a disciplinary situation or fight with management because you don't have consumables. And until and unless it affects you, you don't do it. You never get taught it, you never get trained on how to deal with these things. And learning the theory is again like doing a course and not putting it into practice. So you can sit and learn the whole Labor Relation Act, but until you actually have to go through a disciplinary process with a staff member, you're never really going to really appreciate the steps that it's involved in. What we are trying to do now is a lot of our candidates are writing the exams at 36 months, and passing. And what we are trying to do is, at least for that last 6 months of our registrar rotations, for example, we make them junior consultants. And they work in that capacity almost to try and get some of that management and administrative experience in. I think it's very difficult at an undergrad level to try and introduce that, simply because from a medical legal point of view, they're not allowed, even as an intern, for example, you're not allowed to sign documents or. So you may be able to show them while you're doing it, but they don't really get involved in it. So I think the ideal environment to start that is with internship and com service to start introducing those kinds of concepts. I think not everyone can be a good clinician and a good manager. Some people, like what you call the soft skills, are absolutely essential. How you talk to people, how you interact with people, how you encourage people, how you reprimand people, how you almost try and correct something that was done wrong. Uh, you know, that whole approach can make or break a situation or a person in terms of how you deal with that. And again, emotional intelligence and how you interact with people. People who are good clinicians don't necessarily make good leaders or good managers. ideal would be to get a really good mix of both those skills. Again, you can teach softer skills. You're not innately born with. Some people are just the people's people. They can talk and they can manage and they can interact. And you can, like they always say, tell someone a lot of nonsense in a nice way and they go out saying thank you, kind of concept. Um, but I think we don't do enough of it. And part of the reason is because we're uncomfortable with it as the seniors. And again, it's because we were never taken through that process. A huge, important part of the entire journey for me is mentorship and how you use what you've learned to almost reinforce skills and growth and development in the junior staff. And it's giving of yourself and your time and your experience and your knowledge and your journey, not necessarily clinical experience. Clinical experience, people can sit and learn. You can sit at a book and watch multiple videos and podcasts and whatever, and you can learn lots of skills and clinical stuff. It's the softer skills, how you talk to family and how you explain things to patients and family, knowing how to let people die with dignity. Uh, you know, you've got to learn those skills. And unless you have examples that are good enough for you to follow, the junior staff are just going to continue with bad habits and reinforce those bad habits going forward. So it's up to us as the seniors. And by seniors, I don't mean the oldies. I'm talking about anyone who's senior. A reg is senior to an MO. An MO is senior to an intern. So it's at every single level that we can try and reinforce better, compassionate care, ethical behavior. Uh, Simple things like you examining a patient, do you cover the patient and close the curtains? And we walk past our juniors doing it all the time. And how many of us actually go there and say, you know, just pull the sheet over the patient or close the curtain? Or how would you feel if that was your family member or your granny or your aunt or uncle? Treat patients that way. Simple things like that make a huge difference. And I think the realization in us that it's not always about the antibiotic and the antihypertensive and the thrombolytic that you're giving the patient. It's how you make that patient feel while you're busy with them and how you interact with them. And those are the soft skills for me that I think we need to really push for and inculcate in our younger generation, and perhaps even in our colleagues. I mean, we see so many times where people of our own generation or colleagues of ours who are specialists that do things that are not ideal, and how we deal with that and how we get that message across to say to them, well, are we teaching people the right values almost? And for a lot of people, those are soft things, they're nonsense, and we're here to treat the patient. And actually, there's so much research out there that shows how you make the patient feel, how you talk to the patient, how they feel when they leave your room. There's a huge impact on their recovery and how they feel and the treatment that they get. So I think it's important for me that those kinds of things are also added into just the academic and clinical training.
To some extent, at least recognized or commented upon or commended if somebody does it really well.
Positive reinforcement in those things is huge. And, if you can get them to appreciate the impact of what they've done, and then for that to be the example for others to follow, it's huge.
One of the things you touched on, which I really struggle with as a medical officer myself, and you said with colleagues that are also specialists or on the same level as in the hierarchy,
Yeah.
I struggle to give advice or to even take advice if I'm on the receiving end from somebody who is in the same job title as I am. If I see a colleague who's in the same team as me or whatever, doing something that I wouldn't do, or them seeing me doing something that they wouldn't do, it's tricky to correct their ways, for lack of a better word. It's very easy when it's a comm serve or an intern or a student. You feel that you have the gravitas to give them a helping hand. But if it's someone on your level, you just sort of look away and walk past. You do what you do. That's your style.
Yeah, I guess that's true. It never gets easier, but I think it's also about how you do it, and what you say and where you say it. Reprimanding someone on a ward round,
And in front of who also.
yeah, saying something to someone about having done something wrong or not picked up something on a big ward round, in front of everyone, is not maybe the most appropriate way to do it. It comes down to your interactions with the people when you're not having a difficult situation. Do you have a good enough relationship with the other MOs in your unit? Do you have Can you discuss things that are controversial without getting into a fight? Can you sit and have a tea break together and talk about something that's happened without being insulting and derogatory and you know making the person feel less than? So it's how you do it. And like I said, you need to develop the skill of being able to tell someone something and not having them feel like you criticizing or undermining or insulting them. It's difficult, and it also depends on the other person's emotional intelligence and how they take criticism, what they feel is criticism. And again, those are soft skills that we need to learn. I don't think any of us are born with that innate ability to deal with difficult situations. And it comes with experience. You may mess up the first few and not, say something that's wrong and go home and think about what could I have done differently. Role plays, I find, are a really good way of dealing with those situations, particularly if you put people who are having a difficult situation and you trying as the senior to deal with that, conflict between two colleagues who maybe are at the same level or at a junior level, and you're trying to deal with that. Do you put them into a situation and you say, right, let's take a step back. You put yourself into this person and you switch roles and you put them into different situations, and you get them to see what they're doing that is wrong and how they could better deal, and you get them to do it. You don't have to tell them how to do it. The idea is that you need to get them to a point where they can understand that actually, I didn't look at it from your point of view. I was just, looking at it from my point of view, saw it like that and reacted to it. But if you put me in a situation where I've got to look at it from the other person's point of view, do I deal with it differently then? So I think it's not something that we know innately, and it's not something that we are able to deal with, but it comes with experience, it comes with that growth and that journey, and also the appreciation that we don't always do things the right way. And I think for junior staff to appreciate that senior staff don't know it all. We're still learning. We still, and one of the big things for me is being able to say, I'm sorry or I made a mistake, even as a senior. And I always, if there's a problem and I haven't seen it, or haven't done what I needed to, or haven't reacted in a particular way, I will go back and say sorry. And it doesn't make you less than anything by being big enough to do that. If anything, I feel that it makes you the better person. It makes you the bigger person by being able to say, I made a mistake or I'm sorry. And that's a huge lesson for staff to learn, because it also doesn't prevent them from then owning up to things that have happened and, mistakes that have been made. And the big thing for you, take an M&M, for example. It's very difficult sometimes to sit in an M&M and say, oh God, how could they have done that? That's such an obvious thing. And for you to be able to stop yourself doing that and to deal with the situation that an M&M with a patient has died potentially. to turn that whole situation into a positive situation. That the person who made the error or that didn't do something still feels that they're not being torn apart and taken, to shreds in terms of whatever's happened. And you feel guilty enough every time a patient dies anyway. And now you have a senior who sits there and says, "But how could you be that? And why didn't you do this?" And it's not reinforcing any kind of positive thing. And it also doesn't reinforce any kind of future acknowledgement of I made a mistake. So it's how we deal with those situations. And a lot of it is emotion. I keep coming back to emotional intelligence and being the compassionate, kind person. And we forget a lot of that in our interactions. And I think because we work in very stressful environments where people are tired, you're overworked, you're understaffed, it's often very difficult to be that kind, compassionate mentor and example for people to follow.
Yeah, I agree. In our environments that we work in, when you have to put your best foot forward and be compassionate and kind and everything, but you are overworked and understaffed, and there's a long queue of people waiting outside to be helped by you, and you getting stressed out when you discharge one and three people come. How do we make a space for mentorship and teaching of students and having students in the emergency room that doesn't add to that burden on the staff that are on the floor, the registrars, the medical officers, the consultants? From a personal experience, it depends on the mood I'm in, and it depends on how busy the unit, how much capacity I have to teach students, because I mean it depends on the level and what year the student is in. Often sometimes they can be really helpful and make things go faster if they've got a good summary and you agree with them, and then they can help you with the bloods, etc., and then it makes things more efficient. But then the other side of it is when they've got a not so accurate summary, you have to then give them a half an hour tut on their thought process, and then you have to do everything yourself, and then you end up walking away in a rush.
Very difficult because I think again comes down to what we spoke about right at the beginning about teaching and whether you want to teach and whether you don't want to. And there's some people who just not interested and they get pushed into that situation because I'm the doctor on shift and I've got these three medical students who are wanting to present. They've clocked a patient and they want to present. And like you say, I just want to get rid of the next 10 patients that are waiting in the queue and hand them over to whoever needs to see them for admission. I think the general thing then is to get people to play to their strengths. You have some people in the unit who are really keen to teach. And even at an intern level, I've got an intern at the moment who's really keen. I mean, she junior, just starting, wants to share what she has. So how do we encourage that? Without compromising what she's doing, making sure that she's being supervised, that she's not teaching the wrong thing, but still encourage her to do that and give her the space to grow and develop that skill. Um, so say to them, today Dr. So and so is going to do a tut with you. And, you say to, even if it's an MO, you know, this is a really interesting ECG, for example. It's basic stuff. It's not sophisticated, fancy, Brugada changes and stuff like that. It's a simple ECG, STEMI ECG. Sit with them and go through it because it reinforces your own knowledge, but it's also then developing that skill. So I think it's trying to get people at a different level to teach what they know at that level and playing to their strengths. So, you may have an MO in the unit who's really keen on ultrasounds, does lots of ultrasounds. Then you say to that MO, you say, you know what? You did a really amazing echo yesterday on this patient. The patient's still in the ED. Don't you want to take the ultrasound machine, show the students what you picked up? So get them to play to their strengths. Forcing someone and giving them a topic and saying, go and teach this. may not be your area of expertise or your area of interest or your area of strength. So if you can get people, and you need to know your staff in that instance, and you need to know what their areas of interest is. If you get someone to teach something that they like, they're going to be so much more passionate about it. That interest and that excitement in that topic is going to come across. So, if somebody says, I'm really keen on acute stroke, if somebody says to me, teach the rages on the round, or you have an acute stroke patient on the round and you do a tap with them, you're going to be more enthusiastic about it. You're going to be wanting to talk about it and share that knowledge. So it's no longer a chore. But if you tell me, I don't know, teach someone about ECGs, do it because it's stuff I should know, but it's not really something that particularly like lights my fire to say, oh, I'm really keen on this.
Yeah.
But there are other consultants in the unit who do that really well. So can we use them to do that? I think in terms of the burden of and I call it a burden because, like you said right at the beginning, the fact that you've got so much other work in the unit, both on a clinical, managerial, admin level, and now you've got these little students that are there that are almost a nuisance to you because you've got to find time to teach them. But if you go back and you think of how you felt when you were that student and how horrible it was that you just got brushed off by a senior, and you think about it, when you're a student, you're enthusiastic, you're keen, most of the time. You get the odd ones that are really there just because they have to be. But on the whole, they want to learn, they want to develop the skills, they want to pass. And you've got the senior that totally stamps out all that enthusiasm. So put yourself back a few years and think of how you felt when you got, just I'm busy now and I'll see you later, or let me finish my work and I'll do a tat, and then you don't do a tat with them. I've seen it with my daughters now, having both, done one just done and one in final year. And they come home and they're so excited when they've presented a case to a consultant or head of unit, and they've gotten good feedback from the presentation, and they had a really great chat with so and so. And then by the same token, they come home and say, so and so was horrible to us today. I mean, I don't know what they expect of me and why, they shouldn't be sending us to these people. And so when you hear it like that, and I mean, this is personal, and I sit and I think, okay, maybe that's how we're treating our students. And with a lot of them, their friends are coming through our units now, and they'll come back and they'll say, oh, so and so said they had a really good tat in your unit, or such and such consultant was really horrible to them on the ward round. So you almost get to hear the other side of the story. You realize how important it is, because if we build on that level, think of what amazing doctors we're creating, or we're helping to create.
And I think you said something really important there. From a leadership perspective, if you tell, or if you ask rather, one of your colleagues to do something, like take the students and show them how to do your echo, or give them a tat on this, or take half an hour, you can go and listen to the student's presentation. If you alleviate their stress by giving them a task in terms of take your time, do this properly, it's value adding stuff. Don't worry about the queue for the next hour. The queue will be the queue. It's not going to finish. Just spend some time doing something like this that you will enjoy and they will enjoy.
Yeah, I think we need to, there's such a focus in our health system on pushing a queue and waiting times. It's become a matrix by which we get measured, by which we get judged, by which we get assessed. If you think of people coming into, performance areas, that your waiting time needs to be 5 minutes for this and 2 minutes for that and 20 minutes for this, and the minute it's 1 minute more than that. So that whole focus for me on waiting times as a matrix is become so distorted And the realization that it's more about what you do with the patient when you have that patient than about pushing to meet those targets. Yes, it's great to have waiting times. I mean, the UK NHS hospitals at the moment in an ED have got a waiting time of 15 hours for a patient even to be seen post triage. So those patients are still being seen ultimately. So it's an important factor. But if we can move away from the focus on that being the target, and that we provide quality care and proper intervention, and people not having that focus that I've got to clear the triage queue, and I've got to clear the priority 2 queue, and I've got to get through these patients. And you're just going from one patient to the next. So you're not really focusing on what you're doing with the patient that you have now, or with the student that you're teaching right now. Because your mind is already on 5 patients down the line that you've still got to see. So difficult to really implement completely because of our challenges in our environments, with the staff shortages, and with the environments we have with limited equipment, limited capacity. So all that impacts what you're doing with a patient or with a student. But I think if we move away, not completely, but to a large extent, from pushing a queue and focusing on waiting times, we will start changing that thought process, that it's about the patient and the student that I have in front of me right now. But it's also about the seniors then creating that opportunity, like you said, giving them that opportunity to say, from 10 o'clock to 11 o'clock every day, this is when we do teaching. Let's do a TAT, or let's do a sim, or let's do a role play, or whatever it is that you want to do. And it's also about finding exciting and interesting ways of teaching what you need to teach.
With regards to different ways of learning, like you've touched on, in exciting ways, new ways of learning, there is such a easy access to information these days through different mediums. Podcasts in emergency medicine are huge. There are YouTube videos that are really great for physiology. There are apps on your phone. There's EM guidance. There's Ambos. There's Up to Date. There's AI now. That's all developing at a rapid pace and has developed over the last few years into a very day to day usable, accessible
Yeah.
information source. From an institutional point of view or from a educational point of view, where people are getting all of this very usually high quality stuff if it's from a reputable source in their own means, how do you embrace that from a curriculum or university point of view, and use it to the best of your advantage and work with it, because it's certainly not going to go away or change, and people are going to use it to their own level of comfort.
I think it's also a very generational thing. Example, my daughter's generation. They've learned, they've studied on a device, and using apps and podcasts and things like, YouTube videos and things like that. My generation didn't. I sat with a textbook and I had to learn that. So it's been much more.
And listen to the prof. Yeah.
Yeah, and you went to a lecture and you took down notes from the lecture. But that's how we learned. So you've got to be able to move with the times of realizing that. I mean, like my daughter said to me the other day, one of these days you're not going to need to write an exam, because why are you writing an exam? Why do I have to sit there and learn something by heart to be able to write an exam when I have it at the tip of my phone or my device? Think of us in an ED now. You know, I had to literally sit and write down the criteria for a well score and calculate or work out
Mm.
sodium deficits with a formula. You don't need to do
Yeah.
that anymore. You've got an app, and why not? It's made life easier, it's
Mm.
there, it's accessible. So it's how we embrace.
It's safer.
Yeah, it's safer. You make less mistakes. I mean, you think of radiology, for example. Artificial intelligence reports on a CT have a zero point 0.7 or something percent chance of having an error. Human reporting is about 15%. So, no brainer. There's enough evidence to show that using an app or using a template for something to calculate values is more reliable. So why would you want to do it any other way? So it's how we embrace those things and the realization that we can make our patient care better. We can make our teaching better. Algorithm based protocols on clinical management for me are very important, and we're working on putting together a booklet like that. So, for example, an approach to chest pain. Is your patient stable or unstable? If the patient is stable, what do you want to do? If the patient is unstable, what do you want to do? And I think if we can teach that kind of an approach to most clinical situations, we're winning. We pretty much far down the pathway in trying to do that. Hopefully, we'll get it done fairly soon and be able to put that out. Rather than teaching people every single clinical condition and how you would manage. Because if you have an approach to a broader topic, for example, chest pain, you won't generally miss anything because you're starting at a very broad level. And based on what your algorithm shows you, you'll be able to work down to more specific. And you may not come up still with a definitive diagnosis, but you'd have narrowed it down to the life threatening conditions. I think that's important for me. And if the technology allows you to do that, then why not?
Or at least augment that.
Exactly, but it takes away the stress and the unknown. If you have something to augment, like you say, what you're doing, to be able to fall back on a predetermined value scale. The other big area for me is using simulation training, and I think emergency medicine particularly lends itself to using simulation training for different scenarios because you can create the high intensity, you can create the unknowns, you can create the variables that come in a safe environment that creates that learning. And then obviously your clinical situations then reinforce that. So we are using simulation training a lot more. And the types of simulation devices and mannequins that are now available, you can literally recreate every single scenario that you want. And if we can get that, particularly at an undergrad level, it's a safe space. You have a proper way of doing it with the debriefs, with the reinforcement, the practice. You can practice, for example, a simple thing like putting in a central line. You can practice multiple times in a simulation environment so that you're confident enough. And it's not to say you'll never create a numeral, but your chances of doing it are less because you've practiced the skill. So I think if we can use things that are accessible, that are available to enhance that whole teaching environment, it takes away the stress from us as teachers, but it also enhances the learning experience for the students.
Awesome. And then last question to end off. If you had a magic wand and you could wish for anything to materialize in, well, let's say healthcare in South Africa, but specifically emergency medicine, without a concern of budget or time or whatever, it would just pop up tomorrow. What would that be?
Sure. I can think of a few, but you want one. I think for me, the growth of emergency medicine as a specialty in country, the recognition and the appreciation of what we do by our colleagues in the other specialities is a huge one. Um, it's beginning to change where, for example, the physicians and the surgeons are really appreciating that we're no longer just the casualty officer running a shunting service for patients from, entry into their wards for them to do the wonderful definitive management and surgery and medical interventions. The appreciation that we do know what we're talking about, that we do know what to do, and that we do know how to manage our patients, and we are making a difference. So that growth, um, and the really great thing for me is that is growing, particularly in the private sector. Emergency medicine was always a public sector speciality, and you did it in a government teaching hospital, academic environment. But the growth and the realization, both in the private sector as well as out there in the public, to appreciate what we do and that we are speciality and that we get recognized as such, and that we do have a positive and an impactful role to play in a patient journey. And I think more so that we have the most important role to play, because we're the most important part of that patient's first half hour, golden hour journey into the health system. And how we treat our patients, how we interact with our patients, makes a huge difference. So I think if we can get that recognition and realization, and together with that, the growth in post creation and recognition that we need specialists in our emergency departments, and it does make a big difference to patient outcomes, is a big one for me. But we've just got to keep pushing. I think we've got to keep the momentum going and the fight going, and it's not always easy.
Awesome. Well, thank you for that, and thank you so much for the interview. That was, I'm sure our listeners will find that very interesting and engaging. And yeah, thanks so much for joining.
An absolute pleasure, Daniel. Thank you for having me.
That's all for this month. So just to recap quickly, we spoke about the journey of emergency medicine as a speciality and how that needs to be recognized more by other specialists. We spoke about the traditional short courses and their appropriate use. We then moved on to skills such as management and leadership, which are just important to teach as clinical skills are. We ended off by chatting about how meducation is changing for the better with the augmentation from technology, and how teachers need to adapt to benefit from this. Be sure to review and subscribe on all of your main platforms, and please send to a colleague or friend who might be interested. If you want to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Thanks for listening. See you next month. Bye bye.